Hi guys, welcome to INI-CET November 2022 Anatomy Recall session. Now last November 2022 INI-CET exam anatomy questions were damn easy. Almost majority of the questions came directly from the revision videos. I am not saying the main module, only from the revision videos we got so many questions. Very easy paper. Now first, this is the session 1 questions. Now, in the session 1, morning session, we got 2 questions from the embryology. Now, see the first question. They are asking incorrect match about the pharyngeal arch artery derivative. This is a direct question and not a new question, very old question only, repeat question only. The first arch forms maxillary artery. So, right, now we see some basic description and then we can come to the questions. Now, we have 5 pharyngeal arch artery, 1, 2, 3, 4, 6. The first pharyngeal arch artery disappears and forms the maxillary artery. The incomplete regression of first arch artery, which in turn result in one tumor called as angiofibroma. I hope you know that. Now the second arch artery forms stapedial artery and the hyoid artery. Second arch artery also regress and forms stapedial and the hyoid artery. Now third arch artery forms 3 arteries actually. Common carotid, external carotid and the internal carotid. Actually, in the third arch artery, one small bud, carotid bud is formed and that carotid bud forms the external carotid artery. So, third arch artery forms in both right side and left side, it forms common carotid, external carotid and the internal carotid. See, internal carotid derived from 2 sources. The distal part of third arch artery and the cranial part of dorsal aorta. The distal part of third arch artery and the cranial part of dorsal aorta will form the internal carotid. So the third arch artery forms only the proximal part of internal carotid. Distal part of internal carotid is coming from the cranial part of dorsal aorta. Okay? Right. Now what about the fourth arch artery? Fourth arch artery on the right side, it forms a right subclavian artery and left side, it is forming the arch of aorta. This is very important question. So many times we got this question. Again, chances are there to ask in the coming NEET exam. In the exam, they will give you the question, fourth arch artery forms. So, fourth arch artery forms, they are not mentioning the side. So, we have to include both sides, right and left. Right to fourth arch artery forms right subclavian artery and left to fourth arch artery forms arch of aorta. So, please don't forget. Now, sixth arch artery, the proximal part of sixth arch artery and both sides will form the pulmonary artery. And this is very important. Another expected question for the coming NEET exam. What is it? The distal part of left sixth arch artery forms ductus arteriosus. That is very, very important. Another expected question for coming NEET exam. Okay. So, distal part of left sixth arch artery forms the ductus arteriosus. Now, another important topic you have to know in the arch artery is most of the time they're asking about abnormal right subclavian artery. In abnormal right subclavian artery, I told you already, the right subclavian artery, it is coming from right to fourth arch artery. Okay. Now this right to fourth arch artery will disappear and the right dorsal aorta caudal part will persist along with the seventh cervical intersegmental artery. Okay. Now, these 2 arteries, they form the abnormal right subclavian artery. Now, this abnormal right subclavian artery, which is going behind the esophagus and compressing the esophagus and in turn cause dysphagia lusoria. That is why the abnormal right subclavian artery is also called as lusorian artery. So, another high yield topic for the coming NEET exam. Okay. So, abnormal right subclavian artery is also called as lusorian artery. So, now these are some basic points you have to know about this question. So, first arch artery forms maxillary artery. Yes, correct. The second arch artery forms hyoid and stapedial. Yes. Now, third arch artery forms common carotid, proximal part of internal carotid. Again, yes. Fourth arch artery forms right subclavian. Yes. But sixth arch artery forms arch of aorta on the left side. This is wrong. So, the answer for this question is, now the fifth statement is wrong. So, C is the answer for this question. They are asking the incorrect match. Okay. Right. Now, come to the second question. Again, embryology question. Now, which of the following are derived from the marked structure? Now, this is a diagram they gave in the exam. Now, in the diagram, the marking is on, now see here, Now this is our notochord and this is our neural tube. Now on either side of notochord, yes, we have in this structure, this is paraxial mesoderm, which is forming the somites. Now just dorsal to the neural tube, we have one special structure here that is called neural crust cells. That is our neural crust cells. So they're asking the structures derived from the neural crust cells. So neural crust cells, yes, it is now recently considered as fourth germ layer. Now so many structures derived from the neural crust cells. Now we have to remember certain basic things. Okay. Now please remember, majority of the ganglions are coming from the neural crust cells. Majority of the ganglions, they are coming from the neural crust cells. Okay, first. Then your meninges, pyometer and the arachnoid are coming from the neural crust cells. And then the glial cells of the peripheral ganglia and the Schwann cells, yes, they are all coming from our neural crust cells. All the pigment cells, your melanocytes, melanoblast, they are all coming from the neural crust cells except retinal pigmental cells. This is very important. Very often they give this wrong statement. Retinal pigment cells are not coming from the neural crust cells. And then adrenal medulla, yes. And then calcitonin producing cell, yes. And in these things, you have to remember the facial skeleton, it is coming from the neural crust cells. And the dermis of the neck and the facial regions, the dermal layer of the facial and the neck regions, they are coming from the neural crust cells. At least remember these important things. Okay. Now, these are some important structures derived from the neural crust cells. If you feel difficult in memorizing this, at least by heart this. Okay. 4 gang, pass 2 blast. This is a mnemonic. So 4 gang means ganglions, all the ganglions, sympathetic ganglion, sensory ganglion, dorsal ganglion, parasympathetic ganglions. So majority of the ganglions are coming from the neural crust cells. Okay. Now pass means pyometer, arachnoid, Schwann cells. 2 blast means melanoblast, odontoblast. Now one more structure I want to add here, that is our conotruncal septum. Conotruncal septum or spiral septum, that is also coming from the neural crust cells. Now it is the septum divide the truncus arteriosus into the aorta and the pulmonary trunk. I hope you know that. Now these are some special structures coming from the neural crust cells. At least remember this. If you remember this, okay, well and good. If it didn't feel difficult, at least remember this. From this itself you are getting the questions. Okay, you can easily eliminate the answer. Now see the question, which of the following is derived from the marked structure? Now odontoblast, I told you odontoblast is coming from the neural crust cells. Sympathetic chain, sympathetic ganglion, they are all coming from the neural crust cells. Melanocyte, yes, coming from the neural crust cells. Now nephrogenic cord, bulbous cordus, it is not coming from the neural crust cells. Conotruncal septum, it is coming from the neural crust cells. Okay. Now we know already nephrogenic cord. I hope you know this. Nephrogenic cord, it is forming the kidney and the gonads. It is derived from the intermediate mesoderm. I told you intermediate mesoderm forms unogenital system. So nephrogenic cord, it is not derived from the neural crust cells. And the bulbous cordus, it is a part of heart tube. Heart tube is coming from, which is called a cardiogenic area. Very good. This planchinopluric layer of lateral mesoderm, that is the cardiogenic area. Again, the heart tubes are coming from mesoderm. So if you eliminate 4 and 5, then easily get the answer. In the answer, you should not get 4 and 5. 5, no. 4, nephrogenic cord, no. Again, we have 4 here. So answer for this question is C is the answer for this question. The nephrogenic cord and the bulbous cordus, they are not coming from the neural crust cells. Even if you don't know the neural crust derivatives, you can eliminate the answer and you will get the exact answer. Option C is right. 1, 2, 3, 6. Derived from the neural crust cells. Okay. Now come to the next question. Now next question from the cerebellum. I told you from 2016 till 2022 we are getting one question from the cerebellum. Every year, every INI-CET paper, AIMS paper from 2016 up to 2022 November INI-CET, we are getting one question from the cerebellum topic. Okay? Right. Again, we got one question from cerebellum. The question is, what are all the cells present in the molecular layer of the cerebellum? Very easy and direct question. So now we have three layers in the cerebellum. That is the outer molecular layer and the middle Purkinje layer and the inner granular layer. So we have three layers. Now middle Purkinje layer, we have Purkinje cells. Now we know the shape of Purkinje cell. Purkinje cell, it is a flask-shaped cell in the cerebellum. Now the axons of Purkinje go to the outer molecular layer, and the Purkinje cell, apart from the dendrites of Purkinje cell, in the outer molecular layer, we have basket cells and the stellate cells. Now these two cells are present in the outer molecular layer. Okay? Right. Now middle Purkinje layer, we have only Purkinje cell. Now this is the axon of the Purkinje cell. Now the axon of Purkinje cell, which in turn end in cerebellar nuclei. Now cerebellar nuclei, which in turn carry the fiber to the other parts of brain. So now I told you already, other parts of brain. So now the question is, the cell carrying the structure carrying the efferent from the cerebellum. So efferent from the cerebellum means our cerebellar nuclei, it is carrying the efferent from cerebellum. If the question is about efferent from the cerebellar cortex, then the answer will differ. The structure carrying the efferent from the cerebellar cortex means then that is our Purkinje cell. So whenever you get the question about the efferent, please be careful. Read the language of the question properly. You have a time. Only 200 questions we have in 3 hours. Okay, so now we have time, only 200 questions. So please go through the question carefully. Don't overread the question. Take some time. Read the actual, see the actual language of the question. So whenever you see the efferent question from cerebellum, you have to be so careful. So efferent from cerebellum means cerebellar nuclei. Efferent from cerebellar cortex means Purkinje cell. Okay. Now 4 cerebellar nuclei we have. I hope you know that. Cerebellar nuclei are dentate nucleus, emboliform nucleus, globose nucleus and the vestigial nucleus. So we have 4 nucleus. Cerebellar nuclei. Please remember the name. This can be asked in the coming exam. Right. The inner granular layer, we have Golgi cell and the granular cell. Another important question. What is that? All the cells in the cerebellum are inhibitory except which cell? Very good. Our granular cell. So granular cell, it is a only cell which is not inhibitory. Very important point. Okay. Now who is carrying the input to the cerebellum? The input to the cerebellum is coming from 2 fibers. One is climbing fiber, another one is mossy fiber. Now climbing fiber, it is coming from inferior olivary nucleus. Inferior olivary nucleus, it is lying under olive. Olive is seen in medulla, just lateral to pyramid. 2016 AIMS exam question. This itself a question. Olive seen in. That's all. Now lying under the olive, we have inferior olivary nucleus. So from the inferior olivary nucleus, climbing fiber directly go to only one Purkinje. From inferior olivary nucleus, the climbing fiber will arise, which in turn goes to only one Purkinje. Only one Purkinje cell. This is a question. Okay. Shall we proceed? This is old AIMS question only. The cells from which of the following goes to Purkinje directly? I think they gave this question in AIMS exam. We got this question. Cells from which of the following go to the Purkinje directly? So cells from the inferior olivary nucleus via climbing fiber go to only one Purkinje directly. Now what about mossy fiber, sir? Mossy fiber dividing into 4 to 5 terminal. Each terminal is joining with one granular cell and one Golgi cell. They form one connection here. That connection is called cerebelloglomeruli. This itself a question. Cerebelloglomeruli is seen in which layer? Granular layer. Go for G. Glomerulus in the granular layer. 3 structures contributing to the cerebelloglomerulus. What are those? Our mossy fiber dividing into 4 to 5 terminal. Each fiber is giving the connection to Golgi cell and the granular cell. Now this connection is called our glomerulus. Now from the granule cell, yes, we have T-shaped fiber. The T-shaped fiber anastomosing with thousands and thousands and thousands of Purkinje. In the diagram, we are seeing only one Purkinje cell, but it is joining with thousands of Purkinje. Okay? Right. Now come to the question. These are some points you have to know about the cells in the cerebellum. Now cells in the outer molecular layer. Now what are those? Our stellate cells. Yes. Basket cells present in the outer molecular layer. Purkinje cell, no. Granular cell, no. Purkinje cell middle layer, granular layer containing granular cell and the Golgi cell. So answer for this question is yes. 1 and 2 are correct. That is answer for this question. Okay. Right. Now come to next question. Yes. Another question from the expected area from the internal capsule. So all the following are correct statement about the internal capsule. Okay, so Charcot artery supply the posterior limb. Retrolenticular part of internal capsule contain optic radiation. The anterior limb of capsule contain corticospinal tract, and the internal capsule has a projection fiber. So now we see some basic description and then we can go to the question. Now this is internal capsule. We know that internal capsule parts, anterior limb, genu, posterior limb, retrolentiform part and the sublentiform part. So internal capsule, yes, it is the projection fiber. It is connecting the cortical area to the subcortical structures. Now what are the parts of the internal capsule? Anterior limb. Now anterior limb is present between caudate nucleus and lentiform nucleus. Now posterior limb is present between thalamus medially and the lentiform nucleus laterally. Now between these two we have an angle, we have a bend, and that is called genu. Now we also have sublentiform part and the retrolentiform part. Retrolentiform part is present behind the lentiform nucleus. Retrolentiform part. Sublentiform part, it is passing below the lentiform nucleus. Okay. These are the 5 parts of internal capsule. Now what are the fibers passing through the internal capsule? I told you to remember at least 4 structures. The revision module I told you, please remember 4 structures. From this only we will get the question. What are those? Now in the genu of the internal capsule, yes, corticonuclear tract is passing. Now in the posterior limb of internal capsule, they have corticospinal tract. Okay, so genu, corticonuclear tract, posterior limb, corticospinal tract. Now what about 2 other structures? I told you one mnemonic also, saroja, sarojini mnemonic. S means sublentiform part which transmit auditory radiations. And retrolentiform part which carries optic radiation. I told you to remember only these 4 details. From this itself, we got the question. They told corticospinal tract passing through anterior limb. No, completely wrong. It is passing through posterior limb. Retrolentiform part, it is transmitting the optic radiation fibers, optic pathway fibers. Yes, true statement. Okay, right. Now come to the blood supply. Now blood supply of the internal capsule, yes. Now we are dividing the internal capsule, the anterior limb, genu and the posterior limb into the superior part and the inferior part. This is superior part and this is inferior part. Now the superior part of anterior limb, genu and the posterior limb, it is supplied by striate branches of middle cerebral artery, which is also called as lateral striate artery. Now lateral striate artery is also called as artery of Charcot hemorrhage. Okay, right. Now the inferior part of the anterior limb is supplied by the recurrent branch from the anterior cerebral artery, which is also called as recurrent artery of Hubner. Recurrent artery of Hubner. Now which is also called as medial striate artery. Now the inferior part of genu is supplied by the direct branches from internal carotid. The inferior part of posterior limb plus the entire retrolentiform part, it is supplied by anterior choroidal artery. I told you the mnemonic also. I told you to remember MCA above and below Rahman in AC. I told you this mnemonic. MCA above and below Rahman in AC. This is a mnemonic I told in the modules. Right. Now come to the question. Charcot artery supplying the posterior limb. Yes, the Charcot artery of Charcot hemorrhage or lateral striate artery or striate branch of middle cerebral artery supply the anterior limb, genu and the posterior limb. This is correct. The retrolenticular part of internal capsule contains optic radiation. Correct. The anterior limb of internal capsule contains corticospinal tract. That is wrong. Only posterior limb. Internal capsule has projection fibers. Correct. So now 3 is wrong answer. We should have to eliminate 3 and the answer is yes. Option C. 1, 2 and 4 are correct. Okay. Right. Now see the next question. Now in the next question, again it's a repeat question only. They gave this question in 2020 AIMS exam. We got this question. The same question they slightly modified and they gave in 2020 INI-CET exam. Previously they gave this question in the FMG exam, 2019 FMG I think, subject to correction. 2019 yes or 18 FMG exam we got this question. So again now we got this question. So back to back, yes, we are getting this question about the pterion. Not true about the marked structure. So it is a meeting point of parietal, temporal, frontal and the sphenoid bone. Yes, pterion is a meeting point of frontal bone, parietal bone, this is sphenoid and the temporal bone. Frontal, parietal, temporal and sphenoid. Yes, there is a pterion. Accessory middle meningeal artery is lying under this. No, accessory middle meningeal artery, it is not present here. Now what is artery present below the pterion? Now beneath the pterion, we have the frontal branch. Frontal branch of middle meningeal artery or anterior branch of middle meningeal artery. That is present, not our accessory middle meningeal artery. Now if the middle meningeal artery is ruptured, then which in turn leads to, yes, epidural hemorrhage. Epidural hemorrhage. Okay. So epidural hemorrhage and the subdural hemorrhage. So epidural hemorrhage is due to the laceration of middle meningeal artery and subdural hemorrhage is due to the laceration of bridging veins. Okay. So now in both these intervals we see the lucid interval. See. Now lucid interval it is seen in both epidural hemorrhage, subdural hemorrhage. You see lucid interval. The best answer is epidural hemorrhage greater than subdural hemorrhage. Recently in 2021 FMG exams back to back we got the question about the lucid interval. So chances are there to ask again in the coming NEET exam. 2023 NEET exam, you may get the question about lucid interval. They will frame some clinical scenario for lucid interval and they will ask you what is the artery involved, where is a fracture, now what type of image you will get in the CT. They can give anything, but the point is you will get one question from the lucid interval because they are giving repeatedly in FMG exam. So it's more chances for to ask in the coming NEET exam 2023. Okay. Now in CT, yes, we know that epidural hemorrhage is looking like it is a lens shape or a biconvex shape or some will say idli shape. Okay, no problem. We can add that to idli shape. The shape of epidural hemorrhage, non-contrast CT. The subdural hemorrhage, it is C shape or the crescent shape. Okay. Right. Now see the question. Accessory middle meningeal artery. First statement is correct. First statement is correct. Option B, that is wrong. Now blow to the lateral side of the face, injure the marked structure. Yes, that is a correct statement. It corresponds to the anterolateral fontanelle of the fetal skull. Yes, that is also a correct statement. So the wrong statement about this question is our option B is wrong. Accessory middle meningeal artery is not present. Now see the next question. Now bleeding as shown in the image is due to. Now this is a question we got. Now here, now can you see the dura here? Now the dura is, yes, we are reflected and we are seeing this arachnoid membrane here. And so this hemorrhage, what we are seeing here is the subdural hemorrhage. Just now I told you subdural hemorrhage is due to the bridging veins. So two questions we got from the simple topic. So answer A, bridging veins is the answer for this question. So patient is having subdural hemorrhage, that is due to bridging veins. Middle meningeal artery, yeah, that is involved in the epidural hemorrhage. Okay, right. Now see the next question. Now which among the following statement is true regarding the course of mandibular nerve? So they're asking some question about the auriculotemporal nerve, okay, and then they're asking question about the buccal nerve, and then they're asking question about lingual nerve and the ophthalmic nerve. So now one thing was sure, ophthalmic nerve arises in the middle cranial fossa and it's a branch from anterior division of the mandibular nerve. That is wrong. Ophthalmic nerve, it is not coming from the mandibular nerve. Ophthalmic nerve is a direct branch of trigeminal nerve. Okay, so 4 is not the answer. You have to eliminate the 4. So now we have option A and C, 1 and 2, 2 and 3. We will discuss that. Now auriculotemporal nerve emerges behind the temporomandibular joint and is a branch of anterior division of the mandibular nerve. Now see the diagram. Now this is our auriculotemporal nerve. Now this nerve I am saying, that is our auriculotemporal nerve. So auriculotemporal nerve, it is not the branch of anterior division, that is a branch of posterior division of the mandibular nerve. Posterior division of mandibular nerve will give 3 branches. Number 1, auriculotemporal nerve. Number 2, lingual nerve. And number 3, inferior alveolar nerve. Inferior alveolar nerve. Inferior alveolar nerve. Now these 3 nerves, okay, they are coming from our posterior division of the mandibular nerve. So now auriculotemporal nerve, which is a branch of posterior division, yes. Now what type of fiber carried by the auriculotemporal nerve? So auriculotemporal nerve carries the general sensory fibers to the adjoining area of the auricle and temple. General sensory fiber means general somatic afferent. Is that clear? General somatic afferent means general sensation to the head and neck. Auriculotemporal nerve carries general sensory fibers from the auricle, adjoining area of auricle and temple. Now same auriculotemporal nerve carries postganglionic parasympathetic fiber to the parotid gland. So this is carrying general visceral efferent. Now GVE column, it is a parasympathetic column. I hope you know that. I think you can recall the functional columns of cranial nucleus. GVE column, it is a parasympathetic column. It carries mainly the secretomotor fibers. Yes. So auriculotemporal nerve contains general somatic afferent fibers and general visceral efferent fibers. So these things again you may get in the NEET exam. Okay. Right. That's all about auriculotemporal nerve. Now next one, our lingual nerve. So lingual nerve, you have to remember only 3 points. First point, lingual nerve receives cauda tympani nerve in the infratemporal fossa. Cauda tympani, it is a branch of facial nerve. Now lingual nerve descends down and that is very close to last molar. And the lingual nerve is suspending one ganglion. Which ganglion? Submandibular ganglion. The fibers from submandibular ganglion directly supply the submandibular gland. And the lingual nerve is crossed by the submandibular duct. This is very important point. And we got that question recently in the NEET exam. So lingual nerve is crossed by submandibular duct. Submandibular duct. So the most common nerve to get affected while removing the submandibular duct is our lingual nerve. 2021 NEET exam question. And then the lingual nerve, which in turn goes to anterior two-thirds of tongue. This is the course. Okay. Right. Now next, inferior alveolar nerve. Now again inferior alveolar nerve, a branch of posterior division of mandibular nerve. Right. Now the inferior alveolar nerve, it is a branch of posterior division. Okay. Now the inferior alveolar nerve passing through this foramen. Which foramen? Mandibular foramen. Again very important image based question. Expected question for coming 2023 NEET exam. They gave this question previously in 2019 NEET exam. They will give the image based question. They give the mandibular foramen and they will ask you structures passing through the marked foramen. So please remember, mandibular foramen transmit inferior alveolar nerve and inferior alveolar vessels passing through the mandibular foramen. Please don't forget. And in turn carries the entire sensory supply to the lower jaw. The inferior alveolar nerve, which in turn comes out through mental foramen after supplying the lower jaw. Lower jaw, entire sensory supply, it is by inferior alveolar nerve by forming the dental plexus. It is supplying the premolar, molar, incisor and the canine of the lower jaw. After coming out of mental foramen, the inferior alveolar nerve, the name is changed to mental nerve. Mental nerve supply the chin and the adjoining areas. Now an important point is the nerve before passing through the mandibular foramen, which in turn gives one motor branch. That branch is called nerve to mylohyoid. Nerve to mylohyoid is a motor branch from inferior alveolar nerve. So please remember, inferior alveolar nerve is the mixed nerve. I hope you know that, which carries sensory fiber and motor fiber. So nerve to mylohyoid supplies mylohyoid muscle and also the anterior belly of digastric muscle. So two muscles supplied by nerve to mylohyoid. Okay, this is some basic points you have to remember for the inferior alveolar nerve. Now see the question. Now auriculotemporal nerve, it is the imaging behind the temporomandibular joint, branch of anterior division of mandibular. One is wrong. Buccal nerve emerges behind the mandibular nerve and branch of anterior division. Buccal nerve, it is a branch from anterior division. Anterior division will give 3 motor branch and 1 sensory branch. Now the sensory branch from the anterior division, that is our buccal branch. The buccal branch of mandibular is a branch from anterior division of mandibular nerve that is piercing the buccinator muscle and in turn gives sensory supply to the cheek, skin over that. So buccal branch, yes, it is the branch from anterior division of mandibular. That's a correct statement. Lingual nerve walks around the submandibular duct, a branch of posterior division. That is correct. Ophthalmic nerve, that is wrong. So option 1 and 4 are false and 2 and 3 are correct. So C is the answer for this question. Okay, right. Now see the next question. Identify the nerve passing around the marked structure. Very easy question, a direct question. This is our fibula bone. Now in the fibula bone, around the neck of fibula, one nerve is passing around that. Which nerve? Our common peroneal nerve. So common peroneal nerve, which is winding around the neck of fibula and in turn divided into our deep peroneal nerve, and this is the superficial peroneal nerve. Deep peroneal nerve and superficial peroneal nerve. So deep peroneal nerve, it is a nerve of anterior compartment of leg. Superficial peroneal nerve, it is a nerve of lateral compartment of leg. Now anterior compartment of leg, what are the muscles we have? Tibialis anterior, extensor digitorum longus, the extensor hallucis longus and peroneus tertius. Peroneus tertius. And the lateral compartment of leg, we have peroneus longus and peroneus brevis. Now tibialis anterior, extensor digitorum longus, extensor hallucis longus, they do the dorsiflexion. Peroneus longus and peroneus brevis, they do eversion. Eversion. There's a movement occurring at the subtalar joint, talocalcaneonavicular joint and the transverse talar joint. Yes, there's some eversion. Movement is done by our peroneus longus and brevis. Now, what will happen if there is an injury to common peroneal nerve? Now, you may get the question in the coming NEET exam. So, injury to common peroneal nerve means the patient will have first loss of eversion. Eversion is done mainly by our peroneus longus and brevis supplied by superficial peroneal nerve. So, common peroneal nerve injury means the patient is having fracture of neck of fibula. Common peroneal nerve winding around the neck of fibula. So fracture of neck of fibula, which in turn result in common peroneal nerve injury. So in the common peroneal nerve injury or fracture of neck of fibula, patient have loss of eversion due to superficial peroneal nerve and loss of dorsiflexion. All the dorsiflexor muscles are supplied by deep peroneal nerve. Loss of dorsiflexion, which in turn result in foot drop. And then patient have loss of toe extension. Extensor digitorum longus and extensor hallucis longus are affected. So loss of toe extension. Okay, these are the points that remember for common peroneal nerve injury. Now foot drop is due to. So foot drop is due to our deep peroneal nerve greater than common peroneal nerve? This is old NEET question, 2019 NEET exam question. That is why I am saying 2023 NEET exam, you may get the question about common peroneal nerve injury. Okay, right. Now see the question. Now in the question, yes, now identify the nerve passing through the marked structure. Marking is on the neck of fibula, and we know the answer. Answer is our common peroneal nerve. It is winding around the neck of fibula. Okay, right. Option A is sural nerve, C tibial nerve, D femoral nerve. So B is the answer for this question. Now, which of the following structure cause lateral rotation, flexion, abduction of the hip joint and the flexion at the knee joint? So now marking is on the 4 muscles. Now first we identify the muscles. So now B is the muscle, middlemost muscle, that is our gracilis muscle. Now C is our adductor longus muscle. And A is our sartorius muscle, and D is our rectus femoris muscle. Now see the diagram. Now this is a diagram for our rectus femoris muscle and the quadriceps femoris muscle. Now quadriceps femoris muscle contain rectus femoris and the 3 vastae muscles. Now rectus femoris muscle takes origin from anterior inferior iliac spine. So rectus femoris muscle crossing the hip joint in the front side. So rectus femoris muscle do hip flexion. The rectus femoris muscle joining with the 3 vastae muscles to form quadriceps femoris tendon. Now what about the 3 vastae muscles, sir? The 3 vastae muscles, they take origin from femur bone. So they don't have any action at the level of hip joint. Why? The origin is below the hip joint. So they don't have any action at the level of hip joint. Now the quadriceps femoris tendon crossing the knee in front and so attached to the tibial tuberosity. So quadriceps femoris tendon do the knee extension. We bend the knee joint only on the back side, not on the front side. So quadriceps femoris tendon doing the knee extension. And please remember, the quadriceps femoris tendon, it is the tendon involved in locking of the knee joint. Now which muscle will do the unlocking? Unlocking of the knee joint is done by, very good, popliteus muscle. Right. Now see the next muscle. This is our sartorius muscle. Now sartorius muscle, it is origin from anterior superior iliac spine. Sartorius muscle crossing the hip joint in the front side. So it will do the hip flexion. Muscle is on the lateral side. So it will do abduction plus lateral rotation. Now sartorius muscle, after the origin, now sartorius muscle, it is forming the boundary for femoral triangle, lateral boundary for femoral triangle, and then it is forming the roof of the adductor canal. I hope you know all these details. Now what's the attachment? The muscle goes on the medial side of the knee joint, attached to the medial surface of tibia. Now sartorius muscle along with 2 more muscles attached to the medial surface of tibia. Now sartorius muscle along with 2 more muscles. What are those? Gracilis and semitendinosus attached on the medial surface of tibia. Now this attachment on the tibia, it is called pes anserinus pattern. Okay. Right. So pes anserinus pattern is formed by 3 muscles: sartorius, gracilis and semitendinosus. Clear? Now these 3 muscles are also called as gyropes muscle. Now gyropes muscle also sartorius, gracilis and semitendinosus. Why it is called gyropes muscle? Because these muscle, they take origin from hip bone and they are inserted to tibia. So they tie the hip bone to the tibia. So they are called as a gyropes muscle. They establish the hip bone to the tibia. So they are called as gyropes muscle. These are all old NEET questions. Chances are there to ask again in your NEET exam. Okay. Now, which are the following marked structure do lateral rotation, flexion and the abduction and the flexion of knee? Now, these 3 muscles attached to the medial surface of tibia. So, they do the medial rotation of the knee and this muscle slightly on the back side. So, they do the knee flexion, mild knee flexion. Sartorius muscle will do that. So So sartorius muscle totally will do 5 movement. Sartorius muscle totally will do 5 movement in the hip joint, flexion, abduction and the lateral rotation. In the knee joint, medial rotation and the flexion. Okay? Right. So sartorius muscle is the answer. Now A is the answer for that question. Okay? Right. Rectus femoris muscle, it is not doing the flexion of knee. It is doing the extension of knee. And C is adductor longus muscle, that will do only adduction. And B is our gracilis muscle. Okay? Gracilis muscle will do the adduction, the main adductor muscle for the thigh. It will not do the abduction of the hip. Okay? So now the answer for this question is A is the answer for this question. Sartorius is answer. Now again this question, yes, from the gluteal region. I told you, gluteal region, another important high yield topic for the AIMS and INI-CET exam. Every year we are getting one question from the gluteal region from 2016. Like our cerebellum topic, I told the same in the revision module, main module. One question will be there in the gluteal region. Okay, in the INI-CET AIMS exam. Now the patient with positive Trendelenburg sign, what is the action of the muscle involved? Okay. So now what is the muscle involved in Trendelenburg sign? That is our gluteus medius and minimus muscle. Now gluteus medius and minimus muscle, they take origin from the hip bone and they are inserted to the greater trochanter of the femur. Okay. Now one time they gave this question. This is the greater trochanter. Now this is the upper part of the femur. The diagram, we are seeing the upper part of the femur bone. Now this is the head of the femur and this is the neck of the femur and this is the greater trochanter of the femur. Now the anterior surface of the greater trochanter, which is giving attached to gluteus minimus muscle. Now the oblique ridge on the lateral surface of greater trochanter, which is giving attachment to gluteus medius muscle. So simply remember the greater trochanter, which is giving the attachment to gluteus medius and minimus muscle. One time in the FMG exam, they gave this question. They marked this bone and they asked the muscle attached to the marked area. That is a very tough question actually. That is the iliopsoas muscle attached to the lesser trochanter. That is the FMG question. Okay. Right. And see this point. Now this is our tuberosity. The one which I am marking there, that is the gluteal tuberosity. Now in the gluteal tuberosity, that is our gluteal tuberosity, our gluteus maximus muscle is attached. 2 times we got this question. The question is, what is the action of the muscle attached to the marked area? So gluteus maximus muscle, what is the action of gluteus maximus muscle? We'll write now. Now gluteus maximus muscle do 3 actions. Number 1, gluteus maximus muscle will do the extension of the hip and it is a main muscle for lateral rotation of the hip. Gluteus maximus muscle also do the abduction of the hip. So 3 actions are there for gluteus maximus muscle. So 2 times in the recent exams we got this question about the action of gluteus maximus. Okay. 2020 we got this question. Okay. Right. Now in 2019 exam, the same question was given. They marked the greater trochanter and the question is action of the muscle attached to the marked area. Just now I told you gluteus medius muscle and gluteus minimus muscle, what they do? They do 2 actions. Number 1, abduction of the hip joint and some anterior fibers, they rotate the femur internally. They do medial rotation of the hip. And these 2 muscles, they also involved in Trendelenburg sign. They stabilize the pelvis on the unsupported side. Act from below. They stabilize the pelvis on the unsupported side. Okay. So again we got this question. The patient with the positive Trendelenburg sign means they're asking about which muscle? Gluteus medius and minimus muscle. Now what is the action of gluteus medius and minimus muscle? Our flexion, no. Lateral rotation, abduction. Now this is wrong. Abduction, yes. And interrotation, yes. That is the answer for this question. Abduction and flexion, no. So the answer for this question is C is the answer for this question. Gluteus medius and minimus muscle, they do the abduction and medial rotation or internal rotation of the hip joint. Okay. Right. Now come to next question. So come to the next question. The rupture of bulbar urethra does not cause the extravasation of blood into which of the following space? Option A, deep pouch. Option B, superficial pouch. Option C, wall of scrotum. Option D, scrotal fossa. Now this question, yes, in the recent exams, in the FMG exam, in the INI-CET exam, in the NEET exam, again and again we are getting this question. 2022 NEET exam, we got the question. They gave the question about the patient is having pelvic fracture. I told you already, in the case of pelvic fracture, the rupture of membranous urethra. In the case of straddle injuries, bulbar urethra rupture. Bulbar urethra rupture. So you should not forget this basic point. Whenever they want to ask any question about the bulbar urethral injury or membranous urethral injury, they will usually go by this clue. 2022 NEET exam, they gave this clue. They gave one image also, but a very easy question. They gave the word pelvic fracture. Pelvic fracture means what is the structure involved? Our membranous urethra rupture will be there. Very direct question we got in 2022 NEET exam. Again in FMG exam we got this question. 2021 FMG we got the question about urethral rupture. Now in 2022 November INI-CET, yes, again we got the question. Now the question is rupture of bulbar urethra. Now bulbar urethra, yes, or the sponge urethra. Bulbar urethra, it is a part of a spongy urethra that is present in the superficial perineal pouch. Bulbar urethra or spongy urethra, it is present in the superficial perineal pouch. So in the case of rupture of bulbar urethra, the urine and the blood, they extravased to superficial perineal pouch. This is superficial perineal pouch. Urine will extravased here. Okay. And we have a connection between the superficial perineal pouch to the anterior abdominal wall. So the urine also extravased to anterior abdominal wall. Okay. Now from there, the urine will go to scrotum and the urine also go to penis. Okay. These are the four areas the urine will extravased in the case of rupture of sponge urethra or bulbar urethra. Now what are the areas the urine will not extravased or blood will not extravased? The urine will not extravased to the ischiorectal fossa. Why? Because we have one fascia due to Cooley's fascia. Now Cooley's fascia, this is the Cooley's fascia, fascia of perineum, which is fusing with perineal membrane posteriorly. Fascia Cooley's go behind posteriorly. It is fusing with the perineal membrane and prevent the entry of the extravasation of urine into the ischiorectal fossa. And the urine will not go to deep perineal pouch. Urine will not go to deep perineal pouch because of perineal membrane. Perineal membrane prevent the entry of urine into the deep pouch. And we also have the urine will not go to thigh due to the fascia lata. Now these areas the urine will not extravased. Okay. Now see the question. The rupture of bulbar urethra does not cause extravasation of blood into which of the following space? The urine will go to superficial pouch and it also go to the walls of scrotum. Now option A and D both are wrong. The urine or blood will not extravased to A and D, but it's a single best answer type. So we have to select one best answer. Now see this diagram. This image is giving some clue for us. What is that? Now this is the coronal section of the bladder. This is the bladder. This is a trigone of the bladder. And this is the prostatic urethra. And this is the membranous urethra. And this is the spongy urethra. Very easy to identify. Right? Now membranous urethra, it is present in the deep space. I am writing DS. DS means deep space. I'll use some other color. That is our deep perineal space. Okay, and this is our superficial perineal space. This is our superficial perineal space, which contains the spongy urethra. Now, in the deep space, we are seeing the gland here. What gland? That is our bulbourethral gland in male. Bulbourethral gland or Cowper's gland is present in the deep space. And we have the duct here. The duct of bulbourethral gland. The duct of bulbourethral gland is present in the superficial space, and the duct is present in the superficial space, and that is opening into the spongy urethra or bulbar urethra. Okay. Gland is present in the deep space. The duct is present in the superficial space, opening into the spongy urethra, that is present in the superficial perineal space. So now we have the rupture of spongy urethra or bulbar urethra. I told you duct is present here, duct is opening here. Now through the duct, the blood chances are there to go to the deep space. Because the duct is going to the gland is present in deep space. So chances of extravasation of blood or urine by the duct to the gland to the deep space. So urine may go to deep space. We can consider deep space. Again, that is the wrong answer only. The urine will not go to deep space. But in the worst case, we have to select one best answer, no? So in that case, the urine may go to deep space via the duct of Cowper's gland. Duct is opening in the spongy urethra or penile urethra. Now from the duct, they go to the gland, yes, deep space. So what is the best answer here? The answer is D is greater than A. So D is the best answer for this question. Okay. Right. Now next one. Which of the following artery is not a branch of posterior division of internal iliac artery? Direct question. 2021 INI-CET also we got this question. Again, this is a repeat question. 2022 November, again we got. In the 2021 INI-CET, the question is about all the following are branch from anterior division except. Likewise, they framed the question. Here, they are asking which of the following not a branch of posterior division. Okay. Right. Now, we know that internal iliac artery dividing into anterior division, the posterior division. The posterior division, I told you, will give 3 branches. I gave the mnemonic also. Mnemonic is silk branch. So, S is superior gluteal artery, I is iliolumbar artery, and L is lateral sacral artery. These are the branches from the posterior division of the internal iliac artery. Anterior division will give 9 branches. It is very difficult to remember. No problem. Just read once and then forget. Try to know the branch name. Okay. No need to by heart this. Anterior division will give 9 branch. Number 1, obliterated umbilical artery. Number 2, obturator artery. And then superior vesical artery. And then inferior vesical artery. In the female, it is vaginal artery. And then uterine artery. Uterine artery, it is also the branch of our anterior division. And then middle rectal artery, inferior gluteal artery, internal pudendal artery. So these are the branches from anterior division of internal iliac artery. It is very difficult. So read once and then forget. No problem. But don't forget the branches from posterior division. We have a mnemonic also. So silk is a mnemonic. Okay. Right. Now, what is the answer for this question? Which of the following is not a branch of posterior division of internal iliac artery? Our superior gluteal, iliolumbar, lateral sacral, all are the branches. Inferior gluteal artery, it is not a branch from the posterior division of internal iliac artery. Okay, that is the answer for this question. Right. Now come to next question. One last question in the session 1. Which nerve is blocked when local anesthesia is given below the inguinal ligament during the femoral vein catheterization? Option A, genitofemoral nerve, B, lateral cutaneous nerve of thigh, C, ilioinguinal nerve, and D, femoral nerve. Now see the diagram. So now in this diagram, below the inguinal ligament, the nerve blocked is our genitofemoral nerve. That is a nerve we block below the inguinal ligament for the femoral vein catheterization. Now genitofemoral nerve, we know that it is the branch of lumbar plexus, and you have to know the root value. Root value for genitofemoral nerve is L1, L2. Genitofemoral nerve, it is the main nerve involved in the cremastic reflex. Main nerve involved in the cremastic reflex. So in the old AIMS exam, specifically saying 2017 AIMS exam, 2017 November AIMS exam, the question is, what is the root value for the cremastic reflex? L1, L2. You may get the question again in our 2023 NEET exam, root value for cremastic reflex, L1, L2. Please don't forget this. Now genitofemoral nerve, it is having the two component, femoral branch and genital branch. Now genital branch enter the inguinal canal through the deep ring and then come out via superficial ring, and which in turn supply the cremastic muscle. There is a main muscle involved in the cremastic reflex, and the nerve also supplying the skin of the external genitalia. While the femoral branch descends below the inguinal ligament and then enter the femoral sheath lateral to the femoral artery, and then it pierces the anterior wall of the femoral sheath and the fascia lata and gives sensory supply to the anteromedial aspect of the thigh. These are some basic points you have to know about genitofemoral nerve, and the answer for this question is yes, genitofemoral nerve. That is the nerve we block below the inguinal ligament during the femoral vein catheterization. So these are the questions in the session 1. So now we're going to start the session 2. Now in the session 2, yes, we got some questions, same questions from the session 1. The questions are not the exact same questions. The question asked from the same topic, not the same question. Okay. And we don't have any question from embryology, and also we don't have any question from the histology. In the session 1 and session 2, no question from histology. And in the session 2, no questions asked from the embryology. Okay. Now the first question, yes, from the neuroanatomy topic. The nerve emerge at the marked point. So now this is the cadaveric image they gave. This is the ventral view of the brainstem. Now in the ventral view of the brainstem, yes, now this is medulla, this is pons, and this is midbrain. Now we see the image and then we can proceed further. Now again, this is the ventral view of the brainstem. This is the atlas image. Now this is the medulla, this is pons, and this is midbrain. Now in the medulla, we are seeing the midline elevation. I hope you know the name. This is pyramid, and lateral to pyramid, it is olive. Okay. Now in the lower end of medulla, yes, we are seeing the decussation of pyramid. That is the pyramidal decussation. Decussation of pyramid that is taking place in the lower medulla. Okay. And between pyramid and olive, one nerve is coming out, and that is our 12th nerve. Hypoglossal nerve, 12th nerve, it is emerging between the pyramid and olive. Now lateral to olive, we have 3 nerves. This is 9th nerve, this is 10th nerve, and this is 11th nerve. Now between pons and pyramid, in the ponto-pyramidal junction, this is our abducent nerve or 6th nerve. Ponto-pyramidal junction, between pons and pyramid. Now between the pons and olive, ponto-olivary junction, this is our 7th nerve. Ponto-olivary junction, 7th nerve. And lateral to the 7th nerve, this is our 8th nerve, vestibulocochlear nerve, 8th nerve. Okay. Right. Now in the pons, only one nerve is emerging out. That is our trigeminal nerve. That is our 5th nerve. That is a sensory root of 5th nerve, and the small one is motor root of 5th nerve. Now in the midbrain, now this is our cerebral peduncle. In the interpeduncular fossa, one nerve is coming out. That is our 3rd nerve. And this is a 4th nerve, trochlear nerve. That is a only nerve with the dorsal exit. The nerve will come from the back side, exit from the back side, and then comes to front side. The only nerve with the dorsal exit. And now that's all about the front view of the brainstem. Now this is the back view of the brainstem, posterior view of the brainstem. Now in the posterior view of the brainstem, we are seeing this one, that is the midbrain, and this is pons, and this is medulla. Right. Now in the medulla, we are seeing some elevations. Now these are called tubercles. These are gracile tubercle and this is cuneate tubercle. They contain gracile nucleus and the cuneatous nucleus. These are the nucleus involved in the dorsal column pathway. I hope you know that. Now come to midbrain. Now in the midbrain, we are seeing some elevations. This is superior colliculus and the inferior colliculus. Now superior colliculus and the inferior colliculus together they are called as corpora quadrigemina. So corpora quadrigemina means we have 4 swellings in the posterior aspect of the midbrain. 2 superior colliculus and 2 inferior colliculus. Now just below the inferior colliculus, now we are seeing one nerve which is coming out. I told you the only nerve with the dorsal exit, that is our trochlear nerve, 4th nerve. Now here in the posterior part of the brainstem, we are seeing the 4th ventricle and we are seeing the floor of the 4th ventricle. Now just lateral to the floor of 4th ventricle, now we are seeing these structures. These structures are cerebellar peduncles. This is superior cerebellar peduncle. This is middle cerebellar peduncle. This is inferior cerebellar peduncle. See, cerebellar peduncles, they connect the cerebellum to the brainstem. Superior cerebellar peduncle connect the cerebellum and midbrain. Middle cerebellar peduncle connect the cerebellum and pons. Inferior cerebellar peduncle connect the cerebellum and medulla. Now, an important point is the superior cerebellar peduncle fibers. See, they are going like this. Superior cerebellar peduncle, they are crossing. They are decussating. Where, sir? In the midbrain. Superior cerebellar peduncle, they decussate at the midbrain, at the level of inferior colliculus, exactly speaking. Now, after the crossing, the superior cerebellar peduncle fibers, they go to superior colliculus and also to thalamus. Finally, after the crossing, superior cerebellar peduncle end in thalamus, they go to thalamus and they end in superior colliculus. In superior colliculus, we have one nucleus. That nucleus is our red nucleus. So red nucleus is situated in the midbrain at the level of superior colliculus. So superior cerebellar peduncle fibers, they end in thalamus and in the red nucleus. Okay. Yes. Now another important structure we're going to see in the posterior view of the brainstem is our facial colliculus. Now this is our facial colliculus. Now the facial colliculus, it is due to axons of facial nerve. The motor root of facial nerve fibers, they wind around and produce one bulge that is called facial colliculus. Now what is lying under the facial colliculus? Inside the facial colliculus, we have 6th nerve nuclei is present. So damage to facial colliculus means 7th nerve is damaged greater than 6th nerve. 7th nerve damaged means muscles of face will be affected. Muscles of face will be affected greater than lateral rectus muscle. There is a recent INI-CET question, 2022 May INI-CET, we got this question, image-based question. Chances are there to ask in the coming NEET exam. Now, in the floor of 4th ventricle, in the medulla, we see 2 triangles, hypoglossal triangle and vagal triangle. Identification is very important. Hypoglossal triangle above and vagal triangle below. Okay, identification is very important. So don't do a silly mistake. Okay, hypoglossal triangle above and the vagal triangle below. Now they can give you the question in NEET exam, a damage to the marked part which in turn result in the paralysis of which of the following muscles. They can frame the question like this. Okay. Right, now come to next page. This image is very important image. Very often we are getting this image. Previously they were given this question 2019, 2020, 2021 INI-CET we got this question. AIMS and INI-CET we got this question. And 2022 NEET exam we got this question. So again in 2023 NEET exam, chances are there to ask in the exam. Okay. Expected question, another expected question for 2023 NEET exam. To the last NEET we got this question. Now this is the superior view of the skull base and we're going to identify the cranial nerves. Okay. So in this image, yes, we removed the brain and we're going to identify the cranial nerve. Now this is the lesser wing of sphenoid. In the lesser wing of sphenoid, we are seeing one foramen. This is our optic canal. Now in the optic canal, this is the second nerve, optic nerve, and this is the artery. That is our ophthalmic artery. Okay. Now, this is our third nerve, that is our oculomotor nerve. Okay, and just lateral to that, behind that, we are seeing this nerve, that is our trochlear nerve, and this is our trigeminal nerve, fifth nerve, and this is our sixth nerve. Most of the time they are marking these nerves only. Okay, and the question will be which are the following. Mainly they are marking second, third, they are marking second nerve, third nerve, fifth nerve, and the sixth nerve. The question repeatedly they are giving was which are the following nerve involved in ocular movement, which are the following nerves are not involved in the ocular movements. Ocular movements nerve involved is third nerve, fourth nerve, and sixth nerve. These are the three nerves supplying the extraocular muscles. Okay, so this is the question we are getting repeatedly. Okay, now this is the petrous temporal bone. This is the petrous part of temporal bone. Now here this is our internal auditory meatus. Now in the internal auditory meatus, the seventh nerve is passing and the eighth nerve is passing. Now this is our jugular foramen. Now jugular foramen, this is ninth nerve, 10th nerve, and the 11th nerve. And this is our hypoglossal canal. Now in the hypoglossal canal, 12th nerve is passing. So it's very important image. Again they will ask you. So please go through this image again. Yes. So now nerve image is the marked point. Now this is the pons I told you just now. And this is a pyramid. At the pontopyramidal junction, the nerve marked is our, yes, sixth nerve. That is the answer for this question. Now see the next question. Now fracture of the jugular foramen. Again in the INI-CET exam, they are giving one question from the skull base foramens. In the session 1 we didn't get anything, but in the session 2 we got one question. The question repeatedly they are giving from the skull base foramens. That too they are focusing mainly on the jugular foramen or foramen lacerum only. Now we have to know the foramens present in the bones. What are the foramens present in the corresponding bone? For example, now this is a superior view of the skull base and this is a lesser wing of sphenoid. In the lesser wing of sphenoid, we are seeing only one foramen, that is our optic canal. Now in the greater wing of sphenoid, we have three foramens, that is our round foramen, foramen rotundum, and this is a foramen ovale and the foramen spinosum. Now between sphenoid bone and the temporal bone and the occiput bone, we are seeing one foramen, that is our foramen lacerum. So foramen lacerum is bounded between three bones. That is the question we got in 2022 May INI-CET exam. In 2021 November INI-CET, we got this question. The question is the skull base foramen fracture. That foramen is present between the temporal bone and the occiput bone. Temporal bone and the occiput bone, the foramen present is our jugular foramen. So repeatedly we are getting this question. This is a question they gave in 2021 INI-CET exam. So now here they gave the question frankly. We have a mass in the jugular foramen. So what are structures passing through jugular foramen? The jugular foramen, we have three compartments, anterior, intermediate, and the posterior. Now in the anterior part of the jugular foramen, we have inferior petrosal sinus. Now in the posterior part of jugular foramen, sigmoid sinus, which in turn continue as internal jugular vein. Now in the intermediate part of jugular foramen, we have three nerves, 9th nerve, 10th nerve, and the 11th nerve. Now see the 10th nerve and 7th nerve, they have a common sheath. They are passing in the common canal, whereas 9th nerve, they have a separate canal. Again, that is a question, 2022 May INI-CET, we got the question. Which of the following nerve is passing in the separate canal in the jugular foramen, in the jugular canal? Our 9th nerve is passing in the separate canal, 2022 May INI-CET. Okay? Yes. Now, that's all. Now come to the question. So now the fracture of the jugular foramen present as. So 9th nerve, 10th nerve and the 11th nerve will be affected. So mass in the jugular foramen or jugular foramen syndrome. We have a name for that. The jugular foramen syndrome is called what syndrome? Wernicke syndrome. So please don't forget. So now we have a jugular foramen syndrome, a mass in the jugular foramen or fracture of the jugular foramen. So 9th nerve, 10th nerve and the 11th nerve will be affected. Okay. Right. Now Loss of general sensation in the anterior two-third of tongue. General sensation in the anterior two-third of tongue is carried by lingual nerve. So lingual nerve is not affected. Loss of motor sensation anterior two-third of tongue. See, motor sensation to the tongue anterior two-third, posterior one-third, that is by hypoglossal nerve. Again, that is not passing through jugular foramen. Loss of taste sensation anterior two-third of tongue, that is by cauda tympani nerve, branch of facial nerve. Loss of taste sensation posterior one-third of tongue, that is by ninth nerve. Yes, that is the answer for this question. So D is the answer for this question. Okay, right. Now see the next question. The structure present beneath the marked part. So again, pterion was marked. So pterion, just now I told in the session 1, it's a meeting point of 4 bones. Now what is present behind? Anterior division of middle cerebral artery? No. Posterior division of middle cerebral artery? No. Stem of middle meningeal artery? Again no. Anterior division of middle meningeal artery? Yes, that is the answer for this question. So anterior division of middle meningeal artery or the frontal division of middle meningeal artery. That is the answer for this question. And the fracture of pteria especially dangerous, which in turn due to the potential laceration of branch of middle meningeal artery. Right. Now see the next question. Now the marked space opens into which of the following? Now the marking was given in the sphenoidal sinus. So sphenoidal sinus was marked. So sphenoidal sinus is draining into. This is a side view of the skull. And that marked the sphenoidal sinus and that is opening into the sphenoethmoidal recess. We know that already. Now see some basic points here. Now this is an image. Yes, we are seeing the bulla ethmoidalis. The bulla ethmoidalis contain the most prominent anterior ethmoidal cell. And we also have uncinate process, the part of ethmoid bone. Now between the uncinate and the bulla ethmoidalis, we have hiatus semilunaris. Number 1. If you go inside the hiatus, we have one three-dimensional space that is called ethmoidal infundibulum. And if you go inside the ethmoid infundibulum, then we have one opening here. Now that is our ostium of the maxillary sinus. That is the ostium of maxillary sinus. So ostium of the maxillary sinus, ethmoid infundibulum and the hiatus semilunaris. Now these three structures are called as osteomeatal complex. So osteomeatal complex receives three sinus open in the osteomeatal complex. What are those? Number 1, frontal sinus, number 2, maxillary sinus, and number 3, anterior ethmoidal sinus. Now any block in the osteomeatal complex, these sinuses fail to drain their secretion, which in turn lead to sinusitis. Okay. Right, now see the diagram. Now in this diagram, yes, we are seeing the sphenoethmoidal recess. So sphenoethmoidal recess, which is receiving the sphenoidal sinus. And this is our posterior ethmoidal sinus. That is our posterior ethmoidal sinus that is opening in the superior meatus. And in the inferior meatus, we are seeing the opening of nasolacrimal duct. So what is the answer for this question? So the answer for this question, marked structure is opening in the sphenoethmoidal recess. That is the answer for this question. Now see the next question. The lower brachial injury leads to Klumpke's paralysis. Yes, the characteristic finding is policeman's tip deformity, claw hand, wrist drop and the Horner syndrome. Now see the diagram. Now this is the Erb's palsy and the Klumpke's palsy. So Erb's palsy, that is the upper trunk injury, and the Klumpke's palsy is the lower trunk injury. That is the lower trunk injury. Okay. Now Erb's palsy is due to whenever there is the increase of angle between the neck and the shoulder, whenever the patient is falling on their shoulder, which in turn result in the Erb's palsy, upper trunk injury. Now Klumpke's palsy is due to hyperabduction injuries. That is due to hyperabduction injuries. Now what are the nerves affected in the Erb's palsy? Mainly 3 nerves are affected. Mnemonic is mass or massage, whichever you like, you can keep it. So M is the musculocutaneous nerve. A is the axillary nerve. S is the suprascapular nerve. These are the nerves affected in the upper trunk injury, Erb's palsy. Musculocutaneous nerve, axillary nerve and suprascapular nerve. Now what about Klumpke's palsy? Now in Klumpke's palsy, C8 and T1 fibers of median nerve and the ulnar nerve will be affected. C8 and T1 fibers of median nerve and ulnar nerve affected in the Klumpke's palsy. Now what are the deformities we are seeing? Now in the case of Erb's palsy, the deformity is policeman's tip deformity. Policeman's tip deformity. Policeman's tip deformity. Yes, now see the shoulder joint. The shoulder joint is adducted and medially rotated. The elbow joint is extended and the forearm is pronated. Now what about Klumpke's palsy? In Klumpke's palsy, small muscles are paralyzed. So patient will have median nerve and ulnar nerve. Both are affected. So patient will have complete claw hand. It is a complete claw hand. Plus T1 sympathetic fibers will be involved, and the Klumpke's palsy patient also have Horner syndrome. Right, now see the question. Klumpke's palsy, policeman's tip deformity, no, that is wrong. Wrist drop, no, that is also wrong. Erb's palsy, you will see the policeman's tip deformity. Wrist drop is due to the radial nerve involvement. So now the patient will have claw hand, yes, and the Horner syndrome. We have to select one best answer for this question. So now B or D. Now Horner syndrome means that is a syndrome involving the T1 sympathetic fibers. Now the complete claw hand is due to involvement of C8 and T1 fibers of median nerve and the ulnar nerve. In Klumpke's palsy, what are the nerves affected? C8 and T1 fibers are affected. So what is the best answer? Yes, claw hand B is greater than D. That is the best answer. So in Klumpke's palsy, both are right. Claw hand is seen and the Horner syndrome. But we have to select one best answer. In that case, please go for claw hand greater than Horner syndrome. Okay. Now, which of the following muscle makes the pelvic diaphragm? Another important high yield topic. This question they are giving repeatedly in the AIIMS exam. This is a favorite topic for AIIMS exam. We are getting questions about the pelvic diaphragm or parental nerve. So now, which of the following muscle makes the pelvic diaphragm? I told you from the perineum you will get one question. So the morning session we got the question about the urethral rupture. So the afternoon session instead of asking question about the urethral rupture, they get the question from the pelvic diaphragm. So from the perineum, yes, definitely they will ask one question for sure. So which of the following muscle makes the pelvic diaphragm? So option A, iliococcygeus and pubococcygeus, obturator internus and the deep transverse perineae. Now see the diagram. Now this is the, yes, we are seeing the inferior view of the pelvic diaphragm. Now the pelvic diaphragm is nothing but a muscular partition over the pelvic outlet. Now pelvic diaphragm is made up of two components. One is levator ani muscle plus ischio-coccygeus muscle. Ischio-coccygeus muscle, sometimes it is called only coccygeus. Now levator ani, again we are dividing into pubococcygeus muscle and iliococcygeus muscle. Okay, now so iliococcygeus muscle and pubococcygeus are the part of levator ani. So most of the time we are getting the question that ischio-coccygeus, it is not the part of levator ani. Ischio-coccygeus, it is not a part of levator ani. That is a separate muscle, and ischio-coccygeus along with the levator ani, they are forming the pelvic diaphragm. Okay. Now the pubococcygeus muscle, now see the diagram. Now in this diagram, this is our ischio-coccygeus or coccygeus muscle. In front of that, this is our iliococcygeus muscle. I will write in yellow color. That is our iliococcygeus muscle. Now the remaining in front of that, the entire thing, that is our pubococcygeus muscle. This is pubococcygeus muscle. Now pubococcygeus muscle, they have various subtypes. Now the pubococcygeus muscle, we have pubococcygeus proper. So pubococcygeus proper means they are attaching to the coccyx bone and the anococcygeal raphe. Now some fibers, they go behind the rectum and they continues with the opposite side and they form puborectal sling, puborectalis. Now this part I am talking about. Now see this part. It is going behind the rectum and continues with the opposite side, that is puborectalis, puborectal sling. And some part they blends with the anal canal. They are called puboanalis. Puboanalis, they blend with the longitudinal muscle of the anal canal. Now in female, on either side of vagina, this is a male diagram. In female, yes, either side of vagina, pubovaginalis present. Female pubovaginalis. And in male, instead of pubovaginalis, puboprostaticus. And on either side of urethra, this is our pubourethralis. So just remember the name. These are the subtypes of pubococcygeus. Okay, right. So now see the question. Now which of the following muscle makes the pelvic diaphragm? So pelvic diaphragm is made up of our iliococcygeus. Yes. Pubococcygeus. Yes. Obturator internus muscle. No. This muscle, obturator internus muscle. See here. This is the muscle. That is our obturator internus muscle. That is not the part of pelvic diaphragm. Okay. So this is wrong. And deep transverse perineum muscle, no, again wrong. Deep transverse perineum muscle is present in the deep space. That is not a part of pelvic diaphragm. So answer for this question is option A and B. That is the answer for this question. So see the next question. So 50-year-old male presented with the positive Trendelenburg side on the right side. Identify the nerve injured. So positive Trendelenburg's test on the right side means pelvis is sinking on the right side and they're asking the injured nerve. Now see the diagram. Now for example, this side say I'm writing as right side and this is left side. Okay. Now right side, it is not supported to the ground. The patient is lifting the right leg. Now left side is supported to the ground. Now right side is not supported to the ground. Now what the gravity will do? The gravity try to sink the pelvis on the unsupported side. But that is prevented by the muscle on the left side. The gluteus medius and minimus muscle, they prevent the sinking of pelvis on the right side. Clear? So please write. So sinking of pelvis on the right side. Instead of right side, I am writing the general term, that is the unsupported side. Sinking of pelvis on the unsupported side, right side, is prevented by gluteus medius muscle and the minimus muscle on the left side. Okay, now here, now left side, the gluteus medius muscle and minimus muscle are not working. Gluteus medius muscle and minimus muscle, they are supplied by superior gluteal nerve. Superior gluteal nerve supplies three muscles. What are those? Gluteus medius muscle and then gluteus minimus muscle and then tensor fascia latae muscle. 2022 May INI-CET question. Again they will ask you the coming NEET exam. Superior gluteal nerve supplies all of the following except. So now see this diagram. Now in this diagram the patient is having superior gluteal nerve palsy. So now left side superior gluteal nerve palsy. So left side gluteus medius muscle and minimus muscle, they are not working. So what will happen? Now the patient, the pelvis will sink on the right side. Okay, that is what we are going to write now. So pelvis is sinking on the right side. So right side is unsupported side. Pelvis is sinking on the unsupported side when the patient is standing on the paralyzed side. Standing on the paralyzed side, that is left side. Is that clear? Now this sign is called Trendelenburg sign. So Trendelenburg sign is nothing but the pelvis is sinking on the unsupported side when the patient is standing on the paralyzed side. This is the concept for this question. Now see the question. A 50-year-old male presented with a positive Trendelenburg side on the right side, which means the pelvis is sinking on the right side. So pelvis is sinking on the right side means then the patient is standing on the palsy side. So patient is standing on the palsy side means patient is standing on the left side. So left side gluteus medius muscle and minimus muscle are not working. So left side superior gluteal nerve palsy. So positive Trendelenburg side on the right side means left side superior gluteal nerve is not working. That is a nerve affected. Not inferior gluteal nerve. Inferior gluteal nerve easily you can remove. You may get a confusion about right and left superior gluteal nerve only. So answer is left superior gluteal nerve is affected. Again, this is not a brand new question. Old question. In 2019 JIPMER exam, I think they gave this question. Again, the question is they mentioned the Trendelenburg side, pelvis is sinking on the right side, left side they mentioned. And the question is, they are asking the sound side. Here, they are asking the question about which side nerve is affected. But there in JIPMER exam, old JIPMER exam, the question is, which side is sound side? They are asking the normal side. Now, in this case, the patient is standing on the left side, left side superior gluteal nerve palsy. So, the question is, if they are asking about sound side, so which is a normal side? Right side superior gluteal nerve is normal. So in the future, in 2023 INI-CET, they may ask the question like this. They may give the same clinical scenario and they will ask you which side is sound side. Then you may get the question, similar question in 2023 NEET exam. Okay. Again, Trendelenburg sign, very important topic. You may get the question again. They will give you clinical question. So many times they give direct theory questions. Now for a change, they may give image-based question or they will frame the clinical questions. Right. Now one last question. Now which are the following structure marked affected in the terrible triad? Now this is the front view of the knee joint. Now this is a femur, this is tibia and this is fibula. Okay. Right. Now, between femur and tibia, we have the meniscus. Between femur and tibia, we have meniscus. Meniscus is nothing but they are the fibrous cartilage. Now, fibrous cartilage, they act as a shock absorber. Now, between femur and tibia, we have medial meniscus and the lateral meniscus. Now, on the lateral side, we have two ligaments, medial collateral ligament and the lateral collateral ligament. Now, medial collateral ligament is closely attached to medial meniscus. Whereas lateral collateral ligament and lateral meniscus, they are separated by a tendon of popliteus. So, we have tendon of popliteus that is present between the lateral meniscus and the lateral collateral ligament. Okay. Right. Now, during knee injury, the tendon of popliteus pull the lateral meniscus and save the lateral meniscus. But for medial meniscus, we don't have any structure like that. That is why during knee injury, the most commonly affected meniscus is medial greater than lateral. Because medial meniscus is immobile, which is fixed to the surrounding capsule. That is why that is most commonly affected meniscus. Okay, right. Now, what is the function of medial collateral ligament? The medial collateral ligament prevent the medial displacement of femur and tibia. Okay. Now, see the diagram. Now, the patient is having the severe blow on the lateral aspect of the knee joint. When the patient is planted his sole firmly on the ground. Severe blow on the lateral aspect of the knee joint when the patient planted his sole firmly on the ground. What will happen? The femur and tibia, they move more medially. Femur and the tibia, they move more medially. So what will happen? Which in turn leads to the tear of medial collateral ligament. Medial collateral ligament will be teared. Along with the medial collateral ligament, the medial meniscus also affected. Now, close to medial meniscus, we are seeing this ligament, that is our ACL. So, these three ligaments are affected, then the condition is called terrible triad or unhappy triad. So, terrible triad or unhappy triad, three structures are affected. What are those? Our medial collateral ligament, medial meniscus and ACL. So, now we are going to identify these structures. Now, what is A? A is the medial collateral ligament. Now, what is B? Medial meniscus. What is C? Our anterior cruciate ligament. D, our posterior cruciate ligament. E, lateral meniscus. F, fibular collateral ligament or lateral collateral ligament. So unhappy triad, what are structures affected? A affected, B affected, C affected. So answer for this question is A, B, C are affected. That is the answer for this question. Okay. So that's all, guys. So these are the questions they gave in the session 2. So as I told earlier, NEET exam 2023 exam will be easy only. So don't stress too much. Just go through your notes, revise your notes properly, and wish you good luck for your coming NEET 2023 exam. Thank you so much and see you soon in the next session.